everyone. I thank you guys for having me today. I'm always honored to speak for the CMTA, so thank you very much. I always say this, at least for the past year and a half now, I hate giving talks over Zoom. I prefer to be in person. I like to actually see, people's faces when I speak, but I will try my best. And I'll try and keep it as concise as possible, which sometimes it's hard. I'm just staring at my own slides. But from what I understand, pulmonary questions always come up. There's been a lot of misconceptions about what actually does happen in CMT patients. I always get phone calls. I always get emails from different patients that are basically confused and asking for help on what to do with their breathing. So I'm going to try and keep it as concise as possible. In fact, let me set a timer because I want to give time for questions. So give me 1 second. So that way I save time for you guys for questions. All right. Anyway, I am Dr. Elsayegh. I am a pulmonary critical care physician. I work at Cedars-Sinai. I'm an associate professor at UCLA School of Medicine. And I've been working with neuromuscular disease in general for about 18 years now, and CMT for almost as long. What are the main pulmonary problems in CMT patients? Number one is diaphragm dysfunction. Diaphragm dysfunction leads to essentially shortness of breath. Number two is scoliosis, which is an abnormal curvature of the back. Number three is vocal cord paralysis. And number four is sleep disorder. I want to point out that respiratory issues in CMT in general is relatively rare, not very common, not as common as other neuromuscular diseases. However, sleep disorder is very common. I have tons of my CMT patients always have sleep disorder. And then scoliosis, there's a good number of patients as well with scoliosis. But let's go through these very quickly one at a time. Diaphragm dysfunction. I hope you guys can see my cursor, but basically we have two diaphragms, one on each side of the chest wall cavity. Each of them is innervated by what's the phrenic nerve, which run inside the chest cavity, one on the right and one on the left, this yellow nerve right here. So we think that there's multiple muscles that are involved in breathing, which are basically the neck muscles, your shoulders, the muscles between your ribs, and then the diaphragm. Again, I think they all play a role together in combination, but we think that probably the diaphragm plays the biggest role in breathing. And then as with any other neuromuscular disease, if there is weakness or damage to the nerves causing weakness in the muscles, well, the phrenic nerves can also become weak, and that can make innervation to the diaphragm weaker, making it more difficult to breathe. What are some of the early signs of diaphragm dysfunction? It's usually supine dyspnea. What supine dyspnea means is that when the patients are laying flat, they become short of breath. So a lot of my patients, I'll ask them, do you have any shortness of breath? Are you able to walk without any problems? And the answer is always, oh yeah, no problems at all. And I say, okay, well, how do you sleep at night? They say, oh, I sleep on 3 or 4 pillows. Why do you sleep on so many pillows? Well, because when I'm flat, I just don't feel comfortable, or I'm a little bit short of breath, or I can't catch as big a breath. And these are all very early signs of maybe a little bit of a weakened diaphragm. Then the patients will feel a lot better if they're sitting up or angled up or sleeping on several pillows, or some of the patients that have these posturepedic beds that you can lift the head up, find it more comfortable sleep at an angle. How do we diagnose breathing issues or diaphragm dysfunction? The easiest test is what's called a pulmonary function test. I'm sure every one of you guys has heard of pulmonary function testing, and I'm sure most of you may have done one. There's a pulmonary function test is really 3 or 4 different tests that we do on the patient. The most important for our world here, for the CMT world, is spirometry, which we're going to talk about in a second. That's just one part of the pulmonary function test. So and I'm gearing this talk, just so everyone's aware, I'm gearing this talk to a lot of the questions that have been asked of me and a lot of the questions that have been asked of the CMTA that came back to me. So I may be skipping around a little bit, just trying to answer as many questions as possible that patients have had in the past. But a pulmonary function test, a full pulmonary function test, in general is not needed. Does every single CMT patient need one? The answer is no. What I do is I do a pulmonary function test if a CMT patient is starting to show signs of any breathing issues. Then I like to get a baseline. So I'll do the full test to get a baseline. From that point on, I will just routinely follow them with the spirometry portion, which is a much quicker, easier test that can be done in any doctor's office with the right equipment. And then I follow them. I generally do every 3 months because that's how often I see my patients, but once or twice a year is also sufficient. And the reason is the respiratory decline in CMT patients is usually very slow. It's not rapid by any means. So following it every 6 months, 1 year is more than sufficient. Like I said, I do every 3 months. And the caveat to this is as long as the patient does not have any worsening symptoms. If there are worsening symptoms, we'll obviously do it more often. So here's what I'm talking about with the spirometry. In the spirometry, we really look at what's called the forced vital capacity. There's also a forced expiratory volume, but let's ignore that for a second. So for our for all intents and purposes in the CMT patient, I look at the forced vital capacity and I look at the negative inspiratory force. The forced vital capacity tests the total volume of air one can breathe out. The negative inspiratory force measures the force in which you can take a deep breath in. And we feel that the combination of those two are good indicators of diaphragm function and respiratory muscle function in general. Another test that we can do, this is not as common, but it is a test that we can look at the diaphragm to see how well it's moving. It's called the Sniff Test. And what happens basically is we ask the patient to stand inside of a fluoroscopy machine, which is like an X-ray machine, and it has you just take a deep breath in and out, just to sniff through your nose, and we watch the diaphragm move up and down. And then finally, the test that I am sure every 100% of you guys have had at one point or in your life, and I understand that it's a very unpleasant test, but basically it's an EMG. So what we can do is we can do a phrenic nerve conduction or a diaphragm EMG. A phrenic nerve conduction basically is we stimulate the phrenic nerve at the neck, we just shock it, and we look at the function of the nerve. A diaphragm EMG, we again stimulate the phrenic nerve, but now we put little needles into the diaphragm, and we see the innervation of the actual diaphragm. I put this slide in. Half of it does not apply to you guys, but again, it's answering questions that I've had in the past. What is the difference between bilateral and unilateral hemidiaphragm weakness? And basically what that is remember at the very first slide I showed you, or an earlier slide that I showed you, we have 2 diaphragms, one on each side of the chest cavity. Sometimes patients will have one-sided weakness where one diaphragm is functioning properly and the other side is paralyzed, and others have bilateral where both of them are weak. In neuromuscular patients, the vast majority are bilateral diaphragm weakness. Unilateral, which is one-sided hemidiaphragm weakness or paralysis, usually occurs because of trauma, because of previous surgeries, injury to the neck, car accidents, etc. So generally we damage, or the patient damages, only one phrenic nerve on one side of the body. This is not common in neuromuscular disease, but again, a CMT patient can unfortunately have a car accident or can have neck surgery or heart surgery. And these are all things that can cause, in addition, unilateral diaphragm paralysis. So how do we treat this? The treatment is relatively easy. It's a non-invasive method. And what I recommend is something called a non-invasive ventilator. If you've heard my talks previously or have seen me in my office, I always emphasize this particular slide here. For patients with neuromuscular disease, including CMT, I do not recommend Cpap. And I put a little small writing here. The caveat is only if we're treating pure sleep apnea. I will accept Cpap if the patients are completely asymptomatic otherwise, but only have pure sleep apnea. Otherwise, I recommend something called a non-invasive ventilator. So there's Cpap, which is continuous positive airway pressure. So let's ignore that. There's something called bilevel positive airway pressure, which is BiPAP. Now, this is better than Cpap. However, if we're going to move on to a BiPAP, then I recommend a more sophisticated form, which is a non-invasive ventilator. And I'll show you an example of that in a second. And why do I like non-invasive ventilators? For several reasons. One is, I'll mention when I talk about the sleep apnea portion, I'll mention the second reason, but the primary reason that I like it is it helps maintain a proper carbon dioxide level. And again, the majority of you do not know what this is and probably do not care what this is, but there's a good portion of CMT patients that have come to me and said, that they have an excess amount of carbon dioxide in their body and they're not able to blow it off. The carbon dioxide level goes up. And basically, very quickly, when we breathe in oxygen, we breathe out carbon dioxide. That's how the body works. That's how we survive. That's how we live. If we are unable to remove the carbon dioxide in our body, that is a huge problem that can lead to altered mental status, and then it could even lead to death. So in patients that have severe respiratory issues or even moderate respiratory issues, I always worry about their carbon dioxide level. The best device to blow off this carbon dioxide level is the non-invasive ventilator. Cpap is not going to help with that. And that's why I always recommend non-invasive ventilators above Cpap. Again, I want to repeat this because I've had this question so many times. The only caveat is if you have no breathing issues in CMT patients, if you have no breathing issues, yet you do have sleep apnea, Cpap is more than sufficient and you don't have to worry about the carbon dioxide. But in general, if we're treating respiratory issues and respiratory muscle weakness, my recommendation is to wear the non-invasive ventilator at night for two reasons. Number one is that way it does not impede on your daily activity and your daily normal living. And number two is if you do have sleep apnea, it also treats the sleep apnea. This is what a non-invasive ventilator looks like. Essentially, it's the same as a Cpap machine if you have it, and the tubing is the same, the masks are the same, but it's just a more sophisticated, complex device. I want to point out, because I'm not promoting any one company over the other, when I first started giving these talks, there was only one device out, and that's why I have a picture of it. There are 3 devices out now. All of them work just as well, and I'm not recommending any one brand over the other, and that's why I kind of blurred out the name of this device. The masks, like I said, are the same for any Cpap machine. However, I put this slide in because these are the only masks that I could fit into the slide, but there are about 8 or 9 different masks now. So whatever the patient feels comfortable with. So what my recommendation is, once you receive this device, if you ever receive this device and they send you masks, just ask them for different masks so you can see the different variations of masks and see which one is most convenient and easiest for you to use. So a few key points. This is another important slide for me. It's very important to understand that patients with neuromuscular disease, including CMT, the problem is not their actual lungs. Again, there's a caveat to this, which is scoliosis, which we'll talk about in a second. But in general, the problem is not your lung. The problem is your breathing muscles, your respiratory muscles. Okay, and therefore, when there's a problem with your lung, then your oxygen level may be an issue. So when there's a problem with your breathing muscle, your carbon dioxide is an issue. So what ends up happening, and this is a concern of mine, is patients will go to physicians' offices and say, I'm short of breath. And one of the knee-jerk reactions is to give these patients oxygen. And that is an issue. It's rarely ever needed in CMT patients. And sometimes giving oxygen can actually worsen your carbon dioxide level. And that's why I don't recommend supplemental oxygen. The mainstay of therapy is the non-invasive ventilator. Okay, then the next point on this slide is and again, this next point is very, very rare in CMT patients. We do have a handful of you guys, so I do want to mention it, but for the vast majority, you don't have to worry about this. But in patients that are using the non-invasive ventilator for 24 hours a day or 20 hours a day, and the machine is no longer benefiting them, they can move on to what's called a tracheostomy. It's a little hole in the throat, and you are hooked up to a ventilator that basically is breathing for you. This is what it looks like. It's a tiny little plastic hole in here, and you're hooked up to a ventilator. The good thing nowadays is that this non-invasive ventilator that I showed you earlier can convert into a ventilator, so it's very portable, and you can go around doing your usual daily activities. You have this portable ventilator that you can either carry or wheel next to you. I put this slide in because I've gotten this question a handful of times. I've actually had patients fly in from out of state to see me for this question, and I always tell them it would have been easier for you to call me, but I'm happy to answer it here at this talk. One thing that I have done in the past, and I still do now for spinal cord injury, is diaphragm pacing. It's a pacemaker basically for the diaphragm. When we first started, we were doing it both for neuromuscular disease and for spinal cord injury. Right now, we're doing it more for spinal cord injury than we do for neuromuscular disease. So the answer that I want to give about diaphragm pacing, which we're going to very quickly talk about because, again, there's a huge interest in it, is diaphragm pacing has equivocal results at best in neuromuscular patients. It has very good results in spinal cord injury, but in neuromuscular patients, it has equivocal results at best and has never really been tested in specifically CMT patients. Does it mean that it won't work? Not necessarily, but what I recommend is, it's always on an individual, I consider it on an individual basis. So if it's something that may benefit you or something that you're interested in, you should definitely talk to a physician who has experience with diaphragm pacing and neuromuscular disease. This is what it looks like, and I'm going to fly through these slides for, just sake of time. Basically, it's an external device that has this little thing here that hooks on, to the patient. So it's we implant 4 wires, 2 on each side, 2 on each diaphragm, and then we leave what's called, it looks like a little computer flash drive port sticking outside the body, and you hook up the external device as needed. Again, I don't want to talk too much about this, but if it's something that you have questions about, I'm more than happy to answer. I want to talk about this because, again, I've had a few patients that did qualify for this, and I've had questions about this, which is diaphragm plication. So in unilateral, remember we talked about in neuromuscular patients, usually you have both diaphragms that are weak, but in some patients that have had accidents or whatever other reason have a unilateral diaphragm process. And what happens is your diaphragm gets lifted up into the chest, and it looks like this. So this is what a normal diaphragm on this side looks like. The weakened diaphragm or the paralyzed diaphragm is elevated on that side. And what we do is we basically suture the diaphragm and we pull it down to a more normal location, and that usually resolves the shortness of breath. So post-surgery, we put a suture here, a suture here, we pull it down, and then we suture it to the chest wall down here, opening up the lung. And this is what it looks like post-surgery, where the diaphragm is back in a normal position. All right, next. So the diaphragm also plays a role in coughing. Sometimes patients with weakened diaphragms have a weakened cough. What happens with this is we can't clear the secretions in our lungs, and that leads to mucus plugging, which can cause pneumonia. Again, I'm giving this talk to everyone, but not every single slide applies to every patient. But for patients that do have a weakened cough, right now there is no real good test to measure cough. I just ask them to cough in front of me, and I just, figure it out clinically if it looks like a weakened cough or not, or a strong enough cough to clear the secretions. But basically, this is what the lung anatomy looks like. This is your trachea. You have large airways here, but then you have millions of tiny little airways all out here. And if we don't have a strong enough cough to clear the secretions from all of these airways, we can have, plugging and collapse of those airways, which here you can get mucus plugging, you can get atelectasis, which means collapse of that part of the lung because you can't, it's plugged, it's clogged up, just like clogging up your pipes basically in your sink. Then you can get shortness of breath, and it can sometimes develop into pneumonia. This is what a normal airway looks like, with all the airways nicely open. This is what a mucus plug looks like, where you have this little plug here that plugs up one of the airways. This is what atelectasis is, where you have a mucus plug here that plugged up the right upper lobe, and therefore you have a collapse of the right upper lobe. This is what lungs look like on x-ray, this black here. When you have this, that means there's a collapse of that area. It can be very severe, and you can get collapse of your entire lung as well, depending on where the mucus plug falls. So how do we treat this? Again, fortunately, there's very easy ways of treating it. There's really three things that we do right now. There are three pieces of equipment that we have. The first one is a high-frequency chest wall oscillator. Again, I'm not promoting any one company. This is just the slides that I had in my old talk because this was the first one that came out. But basically, it's a vest that you wear like this, and you hook up to this machine, and it percusses your chest. So it kind of as if someone is percussing or cupping the back of your lungs, and that helps patients clear up their secretions. Many different variations of this device or of the vest, different colors, and there's, I believe, 3 or even 4 companies now that have different variants of this device. Next is what's called the cough assist, and what this does is it helps expectorate the secretions for the patient. So what I like is patients that have a weakened cough, something such as the high frequency oscillator, the vest that I just showed you, is a sufficient device. For patients that cannot cough at all, then a cough assist is more beneficial. And what that is, it looks like this, but what that is a mask that you hold to your face, and it gives you a few breaths of high pressure, and then it gives you a very strong negative pressure, and that forces you to cough everything out. Again, this I only use in patients that have absolutely no cough at all, or a very, very, very weakened cough. The third device, which is a newest device, which just came out on the market just months ago. I want to say, if I remember correctly, it was actually first used in May or June of this year, I hope, unless time is no longer something I can quantify with COVID. It may have been earlier, but it's a relatively new device, and it's new and it's also an old device. And what I mean by that is we've had this system in the hospital for many years, for over 10 years now, and we use it in hospitalized patients, and it works very well. And in the hospital, it's called a metaneb. What it is, it's a device that helps break down the secretions in the lungs. It helps you cough out the secretions. It helps expand the lung. And it's a nebulizer that can deliver medications that can help further break down secretions. So it's kind of a combination of the first two devices in one, plus a few extra added bonuses. But anyway, we've been using this in the hospital for about over 10 years now, and it's called the MetaNeb device. What they did is they came up with the same device for home use, and that's the newer one. It's called Valera System, and I've started using that, and it's been working very well for some of my patients at home, to be honest. This is what it looks like, basically. It's a small device, and there's tubing that goes in here, and again, a mask that the patient will hold to their face. All right, so I want to try and speed it up a little bit because I still have quite a few more topics. But basically, next is scoliosis. And what scoliosis is, and this I've seen more commonly in some CMT patients, but it's a curvature, a bad curvature of the spine. And as you can see, when there is this curvature of the spine, your lung becomes deformed and it becomes smaller than what it should be. And depending on how long you've had it, and if it started in childhood, once the lung sits there for a long time, the lung begins to harden and it kind of sticks in that shape, and that can cause shortness of breath, of course. So it compresses on one or both lungs. It can cause a restrictive type pattern on pulmonary function testing. And then it impedes the movement of the ribs. The patients cannot move their ribs as well as they should. And therefore, it's kind of like a constricting, it's kind of like someone squeezing your chest and having you take a deep breath in. It becomes very, very difficult to do. Surgical correction of the vertebral column is the mainstay of therapy if it has affected your breathing. But I do need to point out a few things, which is, number one, is some studies have shown that surgical correction does improve pulmonary function testing, but it's only usually in severely decreased lung volumes as opposed to normal lung volumes. However, it does not improve, no study has shown that it improves symptomatic dyspnea. What it does improve is that it helps prevent worsening dyspnea. And what I mean by this is if you've had scoliosis, never got it treated, you're now 40, 50 years old, and you're beginning to have shortness of breath. If you decide to do the surgery and correct the scoliosis at that point, your numbers on the pulmonary function test may improve. However, the shortness of breath that you're experiencing will be unchanged. It does not make that shortness of breath better, but what it does do is the shortness of breath that you're already experiencing will not progress. It will not get any worse, at least secondary to the scoliosis. I hope that makes sense. And this is what it looks like after correction. To the left of your screen, you have a patient with scoliosis. And then all the way to the right is straightening of the back. And you can see the hardware in there, the metallic hardware straightening out the back. All right, next, innervation of the vocal cords. So just like the diaphragm, which is innervated by the phrenic nerves, the vocal cords are innervated by the laryngeal nerves. And just like the phrenic nerves can become weak, well, the laryngeal nerves can become weak. When that happens, patients tend to have vocal cord dysfunction. This is, again, really rare, but it can happen, and that's why I like to mention it. In children, you can have bilateral vocal cord dysfunction, but in the vast majority of both children and adults, if you're going to have vocal cord dysfunction, it's usually unilateral. And again, what I mean by that is either both vocal cords or just one vocal cord. And again, although rare, it can happen in some patients. In general, it's more problematic in children than adults, and it can happen as unilateral or bilateral. Unilateral vocal cord paralysis is rarely symptomatic. Patients usually don't even realize that they have it, and it's the biggest issue, the biggest worry about that is that they can aspirate stomach content, acid from the stomach. So if someone has heartburn, right now, what we do is it comes up to our throat, it burns our throat, and then, we take medicine and it makes it feel better. Well, if you have unilateral vocal cord paralysis or one-sided vocal cord paralysis, some of that acid can go into the lung and that can cause pneumonia. But again, not very common. Most unilateral vocal cord paralysis is asymptomatic. Bilateral vocal cord paralysis is a bigger problem that usually occurs in children. So, if it hasn't occurred in you by now, then you shouldn't worry about it. But that makes it very difficult to breathe, and you end up needing a tracheostomy. How do you evaluate for this? If you have any signs of either aspiration or any signs of vocal cord problems, it's a very easy test that can be done in the doctor's office. We put a little scope into the nose and we look at the vocal cords and we watch them move. I like to put the picture of the little boy here who is not in pain at all as we do it, because it really is a painless procedure. We give some numbing medicine in the back of your nose, and usually it doesn't bother the patient at all. All right, the big one, the sleep disorder. So this is what the vast majority of patients with CMT complain, at least to me, about. There are two types of sleep apnea. There's both obstructive and central apneas. We're going to talk about what that is in a second. There's a few other sleep disorders that can occur. One is Restless Leg Syndrome, and the other is periodic limb movements. So what are these things? Well, sleep apnea just is cessation of breathing, which means you stop breathing while you're sleeping. So every few breaths, you stop breathing. Obstructive sleep apnea is secondary to an obstruction of the upper airways, a big tongue, a big neck that causes closure of the airway while you're sleeping. In these patients, they tend to snore. It's like trying to breathe through an obstructed straw, basically. Central sleep apnea is caused by receptors in the brain. And in these patients, again, they end up with sleep apnea, but not necessarily because of obstruction. Well, I thought I mentioned it, but Restless Leg Syndrome, I think I do mention it here, I apologize. Restless Leg Syndrome is discomfort in the legs, which occur after a period of inactivity, meaning sitting at night reading a book or laying in bed, your leg becomes very painful and numb, and you have to get up and move it around in order for the pain to improve. And periodic limb movement is while you're sleeping, jerking of your leg or arms, basically, where these patients will kick a lot or smack their partner by accident at night. So how do you diagnose this? Well, obstructive sleep apnea and central sleep apnea, as well as periodic leg movements, are easiest or most commonly diagnosed by an overnight sleep study. However, I put this next line in because of many questions that I've gotten. CMT patients do not need a screening sleep study. They only need a sleep study if they have symptoms of sleep apnea. Symptoms of sleep apnea are nighttime awakenings, meaning you wake up at night several times for unknown reasons. You're exhausted during the day. You may or may not snore at night, depending if it's central or obstructive. Some patients wake up with a morning headache. Some patients wake up with a very dry mouth. These are all signs of sleep apnea. If that's the case, speak with your physician and order an overnight sleep study. How do you treat this? Cpap is sufficient, and it's more than fine to treat pure sleep apnea in CMT patients. And I mentioned this because at the beginning of the talk, I said I generally don't like CPAPs. If a patient has sleep apnea and nothing else, no respiratory issues, then a CPAP is sufficient. However, of note, CPAP is not appropriate for central sleep apnea. So when you do a sleep study, an overnight sleep study can differentiate from obstructive from central sleep apnea. If the patient has more predominant central sleep apnea, then I recommend either a BiPAP or the non-invasive ventilators that I mentioned earlier. Otherwise, for simple, pure obstructive sleep apnea, CPAP is more than sufficient. Periodic leg movements are also treated very easily. Generally, periodic leg movements are secondary to sleep apnea, and therefore treating the sleep apnea will treat the periodic leg movements, and it stops that issue. And then restless leg syndrome is a diagnosis that we make clinically. Basically, the patient says that I'm in bed, I'm reading a book, not moving my legs, and then all of a sudden I get severe pain in one of my legs. I get up, I move my leg around, or I walk around the room, and the pain goes away. And that's basically the definition of restless leg syndrome. And the way you treat this is there are multiple pharmacological treatments, multiple medications that you can use. Again, talk to a sleep physician, and they can help guide you with the treatment of this. I put the slide in. I was hoping, I put the slide in at the last talk. I was hoping it would be removed by now, but unfortunately not yet. So I always get questions about CMT and COVID. CMT patients are no different than any other patient when it comes to contracting COVID. They're no different with any other patient when it comes to treating COVID. However, patients with CMT and respiratory issues, then the patient obviously has to be more careful, and those patients are at higher risk of complications from COVID. So the goal is not to contract COVID, obviously. I do recommend receiving the vaccine, and if you've already received the vaccine, especially if you qualify or if you have respiratory issues, then I recommend a booster dose. Wear masks for now. I'm hoping that we're at the tail end of COVID, so hopefully I will remove this slide by the time I give my next talk, and it will not be a problem. But for now, let's be smart. Let's wear masks. Let's, receive the vaccine. However, the most important thing is if you do contract COVID, let your pulmonologist know immediately. Don't wait till you have symptoms. It's better to know right away, and that way we can manage things immediately as opposed to when it's much worse and possibly too late. So it is important to stay on top of the infection. And the good news is there are multiple treatments now that we can use, whether it's at home or in the hospital, that if we start early enough can minimize the symptoms and improve survival. I want to add this slide as well. Let me see how much time I have. All right, I think I'm just on time. I wanted to add this slide as well. Again, I wanted to somehow speak about this article, but there's no way I can fit it all in with one talk. So hopefully maybe at the next talk, I can just talk about this particular article. But there is one of your fellow CMT association members approached me. His name is Kenneth Raymond, who does a blog, and it's an amazing blog that I looked into recently. But he approached me because he wanted me to help him write an article on clarifying the misconceptions of CMT-related respiratory impairment. And what this article talks about basically is, and this was shocking to me, that a lot of patients will go to physicians and come home with a diagnosis that has nothing to do with CMT, such as COPD, interstitial lung disease. These are not anything to do with CMT. I don't want to go too crazy into this right now, but I do recommend, I believe the CMTA is also publishing this article at some point. I know that if you look up Kenneth Raymond's blog, it is in there. Recommend it. I recommend reading it, as it answers a lot of very incorrect misconceptions about breathing, respiratory involvement, and CMT. What happens, in just one quick sentence, is patients will go and perform a pulmonary function test because they're short of breath, and then they get mislabeled as either emphysema or asthma or COPD or interstitial lung disease or pulmonary fibrosis, all because of the pulmonary function testing without looking at the clinical picture, and none of you guys fall into these categories. Your shortness of breath and your pulmonary function results are secondary to respiratory muscle weakness and your neuromuscular disease. So again, read the article. I explain, or both Ken and I explain why it's important not to be mislabeled labeled or misdiagnosed because the treatment is completely different. And you're on a bunch of treatments for, emphysema, for example, that aren't doing anything for you, and there's no point on being on them. So again, I recommend reading this article. In summary, I want to emphasize that, pulmonary complications are relatively rare in CMT. And I wrote here, we think, because every time I give this talk, I get hundreds, literally, of patients and questions that will approach me or come to my office and say, wait a minute, I do have breathing issues. So I think it's more common than we think. And I promise one day we will look at how common it is. And I say I promise because I've been promising this now for about 3 or 4 years. And I know Elizabeth and Laurel are going to kill me if I don't eventually look into this one day. But I will try my best to do it with my schedule. And that way we can hopefully have some more concrete answers on how common pulmonary problems are, and if they are more common in one variant of CMT than the other. When problems occur, they're usually slow in onset and slow in progression. However, it is a good idea to have a plan. So what I recommend is always seeing a pulmonologist that specializes in neuromuscular patients, follow up with a center that specializes in CMT patients specifically. And then if you do need equipment, please have them use a DME company or respiratory therapist that specializes in neuromuscular patients as well. Thank you. Questions? I want to put this next slide up, which is my information. I always say if I can't get to your questions today, or if you have any other questions that come up later, please feel free to call my office, and I try my best to answer the questions either by phone or by email. And many patients will attest to the fact that I try my best. Sometimes it takes me a few weeks to get back to you, but sooner or later I do get back to everyone with answering their questions. Okay.
Thank you, Dr. Elsayegh. Just incredible information. We gain so much knowledge every time we hear you speak. So a couple things. The article that Dr. Elsayegh mentioned that he co-authored with Kenneth Raymond. Kenneth Raymond is one of our advisory board members here at the CMTA. We are putting that article up on our website. So in the coming weeks, that full article will be up on the website. It's incredible information. I have it on my wish list for 2022 to have another breathing meeting with Dr. Elsayegh when we cover some of those topics that are discussed in the article. So please know that that's coming if we can get back on your calendar.
In person.
Yes. Oh my gosh. Wouldn't that be wonderful? Yeah, truly. That's the goal. And we're planning our patient family conference. Really, it's a patient research summit in person on October 1st next year. So hopefully we'll all be together. So we've had a couple of questions come in the chat. I don't know if we'll get to all of them. I'm actually going to go to the Q&A section. And some of them have been answered. They were answered in your talk. And otherwise, I'm going to bring a question up on stage so that you can see it. All right, here's the first question. Can you see that, Dr. Elsayegh?
Yes. Yes. Hi, I have CMT and have manifested frequent nasal throat congestion, swallowing issues. Could there be any link to CMT? Well, these are several different things. So nasal or throat congestion could just be allergies, and it may just remember, CMT patients can have any other problem like any other patient. So depending on where I think you're in Canada, so I don't know what the pollen count is or the allergy is there, but nasal congestion could be allergies, pure allergies, and treating the allergies can take care of it. At the same time, you mentioned here swallowing issues. Well, yes, swallowing issues could be related to neuromuscular disease and CMT. And at the same time, nasal and throat congestion, increased congestion, could also be related to CMT and neuromuscular disease. So it's hard to just, it's not a yes or no answer. It could be multiple things. Number one is non-neuromuscular issues, such as allergies, which can also affect your swallowing, believe it or not. It could be reflux, gastroesophageal reflux disease, which can affect your swallowing and cause congestion. Or yes, it can be secondary to CMT and neuromuscular disease.
Thank you. I wanted to bring that question up because the swallowing issue comes up quite a bit. Yeah. Okay, next question is a follow-up to something that you touched on about high levels of CO2.
Yeah. So I wanted to point out that it's not something you worry about. It's not, I don't live my life every day going, oh my God, where's my carbon dioxide level? What constitutes, so that's a medical school question, and that's, I'd have to draw diagrams of what constitutes high levels of carbon dioxide, because it's a little bit more complicated than that. It's not your carbon dioxide that you're looking at, it's the pH of your body that you're looking at. So again, this is going to become very medical school and technical and probably irrelevant to everyone, but the body has to maintain a level of pH, a level of acidity, or being basic, the blood system. Too much carbon dioxide will make your body too acidic, and so you can't have that. So the carbon dioxide level is affected by many things. It's not only just breathing. So you have to, what constitutes a high level of carbon dioxide it varies a little bit from patient to patient. In books, a normal human being, a carbon dioxide level of 40 is normal. Anything higher than that, you have to look at if it's affecting the pH of the body. And if it is, that means the carbon dioxide is too high for you. How would you know? It's not something that you go tell your doctor, hey, I want to get my carbon dioxide level checked, unless you have symptoms. Symptoms of high carbon dioxide level are some of the things that I've mentioned, such as waking up with a headache. So carbon dioxide, early signs of high carbon dioxide are frequent headaches, being a little bit groggy, being not sharp, not on top of things, and then being more altered. As the levels get higher and higher, patients become more altered and more difficult to arouse. So it's something that I always tell patients, if you have a high carbon dioxide level, you're just going to know it. It's not something that you need to really worry about. And for all intents and purposes, if you're normal and you don't have problems breathing, your carbon dioxide level is normal. For example, if you take someone who doesn't have CMT and they live their entire life without knowing what their carbon dioxide level is and not even thinking about it. So.
Mm-hmm. That's great information. Thank you so much. Okay, next question. And this relates to SORD patients. SORD is one of the new genetic mutations, but wanted to share this.
Do you find phrenic nerve problems in SORD patients? My son has shortness of breath when climbing a flight of stairs, running, carrying heavy objects, etc. He had a sniff test, which was negative. Any suggestions? So yes, so some patients have already had sniff tests, and you guys know what that is, which is good. So sniff test is just one test. It's not by any means the standard of knowing if you have diaphragm problems. Can patients have phrenic nerve problems? I don't see why they can't. The fact that your son has shortness of breath when climbing stairs and running, I would need to know more about your son and if there's any other cause of that shortness of breath. But assuming there's no other cause of that shortness of breath, then my recommendation is to look into diaphragm dysfunction a little bit more carefully. So the sniff test is negative, which is good. I would do pulmonary function tests. I would even do a phrenic nerve EMG or a diaphragm EMG to have a better idea. And even if everything comes back negative, if there's absolutely no other reason why they have shortness of breath and everything else has been ruled out, meaning all, asthma, whatever else that can happen in kids, heart problems, whatever it may be, if everything else is ruled out, you can always have a trial of a non-invasive ventilator that he tries at night and see if that helps him.
Excellent. We are at time, and so I just want to let everyone know that if we didn't get to your question today, we will make a note of that and see if we can get that question answered and get back to you. Dr. Elsayegh, thank you so much for sharing your time with us. I know you're incredibly busy. We learn something new every time you're with us.
Thank you so much. And then again, I'm honored that you guys ask me, so I'm more than happy to always speak, and you know that. So thank you.
Well, thank you. And thanks, everyone. So we're going to end the session in just a second. And you can, at the top of your screen, again, you'll see your choices for lounge or session or booth. And we're about to go to our lunch break. So we encourage you to grab some lunch and meet us in the lounge at one of the tables. And then our next session will start promptly at 2 p.m. Eastern time. So have some lunch with us or on your own, but we'll see you at 2 o'clock. Thanks again, Dr. Elsayegh.
Bye-bye.
Take care.
Thank you.
Bye-bye.